Welcome everybody, and today's second presentation is by the Department of Pediatric and Preventive Dentistry at the Center of Dental Education and Research. They are going to present a case of which is kind of much neglected but very important for the child, psychological, functional, and aesthetic needs. I would ask the division head, Dr. Vijay, to come and introduce the topic and start with the presentation. Thank you.
Thank you so much, sir. So normally we do complex cases in CCR, but as a pediatric dentist, I see a lot of ignorance on part of our colleagues within our institute. So I try to present. Last time also I presented something on early childhood caries. This time we are presenting about the knocked out tooth, for which the awareness level is quite low. A little bit help from your side. The people, those who are first responders, maybe in your family, at your home, nearby you, for one of your relatives, or if you are posted in emergency, if you do help a little bit, we can give better survival outcome for the knocked out teeth when the children are playing. So survival matters. We all know about this case, which was a newspaper and a very good achievement of the medical science. So it got a lot of publicity everywhere and the praises everywhere. This is a body organ, and the tooth is also a body organ. So, and we all know that our children keep playing, so they get an injury somewhere, the tooth gets knocked out, but it is not seen that seriously. The tooth goes into the ground and nobody picks it up, and if they pick it up, if they do not consider it important to bring it to a dentist. So for the knocked out tooth is again a rule of golden hour. If it remains wet in saliva or in the saline, or even if it is in the milk, it can be saved. It can be replanted, it can be saved. So one such case happened recently with us and our colleagues in trauma center. They were quite responsive and we could manage such case. So I request our senior resident, Dr. Atif, please come over and present that case.
So good afternoon, everyone. Here I am here to present a case of avulsion which was managed in the Department of Pediatrics and Preventive Dentistry, CDR, AIIMS. So he was a 13-year-old male child who was a resident of Krishna Nagar in Sub-Regional Enclave, who was referred by Jayaprakash Nair Apex Trauma Center to our department with a traumatic dental injury leading to the avulsion of the permanent maxillary central incisor, along with additional injuries such as soft tissue abrasions and lacerations. So the incident occurred on 15th of March at around 7:30 p.m. When the boy was trying, and it happened when the boy was trying to do some stunts on the bicycle. Since he was not wearing a helmet or any other protective devices, he slipped and fell on the pavement and got injured while performing the stunt trick. There was no per se past significant medical history or nor any past dental history was present. At home, the bleeding was stopped by the parents by using a cotton cloth at the site of the injury. And the tooth which was knocked out, it was picked up and kept in a container with the tap water. Then the patient was brought to the our trauma center. So the basic preliminary evaluation was done in the trauma center, followed by the management of the extraoral facial lacerations as well as the intraoral lacerations. Later on, the team of the CDR was contacted, and by which the patient was asked to immediately report to the division of periodontics for further management of the traumatic dental injury. By that time, the child was here in CDR. It was around 10:30 p.m. So this is how the patient appeared to our department with an extraoral abrasions and contusions on the right malar region, which almost extended to the lower part of the orbit. There was also contusions seen in the nasal bridges, upper lip, as well as the chin. We can appreciate the suture of the lacerated sutures, which were present on the right side of the upper lip as well as the chin. In the intraoral evaluation, we found out that there were sutured lacerations present on the labial mucosa of the upper lip, the lower lip, as well as the gingiva. We can appreciate there was absence missing both the central incisors. The right maxillary lateral incisor also showed some extrusive movement, and the left maxillary lateral incisor as well as the right maxillary lateral incisor had mobility present, and there was continuous bleeding from the site of the injury. This was the radiograph which was taken at the time, at that particular point of time, and we can appreciate the empty sockets with the margins of the socket which are highlighted. And this is how the tooth was brought to us in a bottle of saline and stored in a saline. So the final diagnosis that we made was avulsion of the maxillary central incisors both. There was extrusive luxation of the right maxillary lateral incisor and subluxation of the left maxillary lateral incisor, along with a component of dental-alveolar fracture. So as per the guidelines, we initiated the splinting procedure, which is done to immobilize and stabilize the injured tooth, for which the first step is to determine the length of the stainless steel wire, which is used for a splinting purpose. Later on, the site of the injury as well as the socket was irrigated with normal saline to remove out the debris as well as the blood clots, and the tooth was both the central incisors were reimplanted into the socket into the probable anatomic position using slight digital pressure. Repositioning of the lateral incisor was also done, and the stabilization of the entire segment was done using the cotton placed on the palatal aspect. We can see that the two central incisors were overlapping to each other, but this was assumed to be the normal anatomic position of these teeth, and which was confirmed by the patient's father as well as his pre-injury photographs. We also took the radiograph to confirm the position of the tooth, and we can appreciate in the radiograph that the socket is completely approximated with the tooth roots. So this is how the splinting was done. The clean operating field was achieved, and the braided stainless steel wire, which was to be used for splinting, was stabilized at the site over the teeth using resin-based tooth filling material in the form of adhesive. This is how the tooth appeared after the splinting. But once we achieved the stabilization of the tooth, we moved on to soft tissue injuries, and we can appreciate in the picture that there was a degloving injury present, along with the exposure of the alveolar bone with respect to the seen teeth. So this is how we later on managed the soft tissue injury by gingivoplasty, and the gingiva was repositioned into the anatomic position and secured using sutures. So this is how the child appeared to us at around 10:30 p.m. and this is how we were able to manage the injuries at around 11:40 p.m. So this was the 7-month follow-up where we can appreciate that the extraoral injuries were in a healing state, but the intraoral examination found out that there was a poor oral hygiene which was maintained by the patient and inadequate healing was seen. So we thought of continuing with this. We did not remove the suture at this moment. But on the 14th-day follow-up, we can see that the intraoral lesions were also injuries were also healing, and we can appreciate the healing of the gingiva. So we removed the suture, and followed by the extirpation of the pulp as per the guidelines, which has to be removed because of the degenerative changes that is expected after such kind of injuries. So this is how we extirpated the pulp, which was followed by placement of the calcium hydroxide medicament into the canals, and this was the radiograph which was done to ascertain the position of the medicament. This is how the necrosed extirpated pulp was later on sent for the histopath, and we can appreciate the degenerative changes in the second image. And this is how the patient later on came to us after 28th day, where we can see that there was complete healing of the soft tissue, and since there was no mobility present and the patient was completely asymptomatic, we planned to remove the splint. And this is how this image shows the healing of the tissues after removal of the splint. So this is how the patient came to us, and this is how the patient was after a month, approximately a month. Now I would like to call upon Dr. Nilesh sir for further discussion of the case.
Good afternoon. The thing with avulsion is that it's one of the most severe form of traumatic dental injuries which we encounter. And usually as a dentist, we are not accustomed to seeing too many of the blood fields, and it's difficult when the child is panicked and the parents are panicked. So it also forms one of the first visits of a child to an emergency room in a normal scenario. So what we have with us is a guideline which has been given by International Association of Dental Traumatology, and that's what we follow in these scenarios and in the cases. And like what Atif mentioned, we also did the same in this case.
The guideline very prominently says that the emergency management is the key to the success, because within 60 minutes, if the things are done, they are done. If the longer is the delay, or if it is not handled properly, the tooth is not handled properly, then there is necrosis of the periodontal ligament, and the tooth survival is really difficult. So these are the few. The guideline also mentions about a few of the first aid for the teeth. The first is that the tooth which is in avulsed, it should be ascertained whether it's a primary tooth or a permanent tooth, because when the patient or the panic parent is calling us, they are never sure whether it's a milk tooth or a permanent tooth. So we need to just counsel them by saying that what's the age of the patient, and maybe in these days we can even ask for a picture. If they can send a picture immediately, so that we can just give them a probable solution on the telephone. Then second thing is that if it is possible for them, we ask them to pick the tooth from the crown part, the white part of the tooth which is visible, because they do not know about the different anatomical the landmarks. So we just say that pick the tooth from the white part, and if it is possible for them, it needs to be washed or cleaned with milk or the saline or the saliva, whichever is possible for them. If it's in the playground, even a tap water rinsing is okay. And as soon as it is possible, it should be placed back into the socket by the parent or the patient himself. That's the most important thing for the prognosis, and that's what we try to deliver in terms of awareness talks. So if it is there within the oral cavity, we can minimize the extraoral dry time, and the patient is brought to a dental clinic with even if it is he is biting on a handkerchief or any cotton cloth, then our work is almost half done. So then if it is not possible for the parent, or if it is in an emergency scenario like we had in this case, and it is not possible for them to reimplant, then the tooth has to be stored in a proper appropriate physiological media. So what the studies tell us that the viability of the periodontal ligament tissues and the cells which are there, so it is the most probable solution is the milk. The bovine milk is the one which has been recommended, and it has been shown that the viability of the cell is there till 6 to 8 hours. So that's the time period. But like sir mentioned, that the golden hour is the most important in the cases of tooth avulsions. Then the emergency has to be sought. So in the process of the discussion, I will be showing a couple of cases where we can just highlight that what is the importance of the proper handling. So if the tooth is a primary tooth, that is the child is below the 6 years of age, and the tooth is still a milk tooth, in these cases we are not recommending reimplantation. So in these cases, the tooth the bleeding has to be stopped, and other things have to be managed, because there is a risk of damage to the permanent tooth. But there's a cohort which we published, the 596 cases of the sequelae to the traumatic dental injuries, because injury occur in the age group of 3 years, 4 years very frequently. But many a times they are ignored, and when the new teeth erupts around 6 years of age, we see things like this, which are the sequelae or the long-term sequelae of the primary tooth trauma on the permanent dentition, and that's the fear which asks us not to reimplant the primary tooth. So as far as permanent tooth goes, the permanent incisors which are most frequently damaged, there are four main factors which are important for the prognosis. The first is the time elapsed from the injury. So like you could appreciate in the case presentation, we had timelines mentioned, because that is going to be the most predominant factor in terms of survival. Then extraoral dry storage of the avulsed medium. We often get teeth like this, and very often we have to just resort to some of the prosthetic or artificial tooth, because we cannot reimplant the tooth like this with so much of necrosed tissue onto the tooth surface. The moment we place it inside, it will be treated as a foreign body reaction, and there will be more damage than the good which can be done. Third step is the stabilization. Like in the case you saw, there was a wire and composite splint which was used. Composite is the normal filling material which we use for the teeth. So the wire is placed there, and like a normal cast, it is just used for stabilization. And it is believed that the physiological splinting, the splint which can allow the normal movement of the tooth, normal biting forces to have their work, they are the most important for the better survival. Then last and the most important as a dental professional is the monitoring and adequate management of the complications. So in history, in the literature, and even in our clinical practices, we are often seeing complications of reimplantations, because people reimplant the tooth, they think that they have done their job, and they do not follow the patient, and there is also a problem with the compliance. So the patient don't report to us. So there's a case which I would like to show here, the case of tooth avulsion with dry time of less than 60 minutes. That means The patient did everything which could be done within reporting within time period, which is regarded as the golden hour, and it was managed by reimplantation and splinting. But the problem went on because the patient did not report back, and when he reported, it was already 2 months which had gone. And if you can appreciate, you can see that there are some signs of resorption in the normal the root morphology, and also the bone which is there. And since it had started, and we did our best, but we just could not do anything. And you can clearly appreciate the bone pathology which is extending there onto the root surface and into the alveolar process. So a kid of around 8 years or 9 years, if he is having such a severe bone loss, then you can expect what will be happening in the rest of the life. Similarly, a case, this is another scenario where the child of 8 years of age, she had reimplanted the tooth within the socket. The story goes like this, that she was playing and near the home, she fell down, the tooth got knocked off, and because she was afraid that the parents will be scolding her, so she just put it inside and never told anybody. So when she came back after 5 years of trauma, and she had this abscess, which we can appreciate in this clinical picture. And then the radiograph showed a marked radiolucency, which was cystic in its appearance, and the root was immature. This is called immature root because the root is complete, the tooth is formed. Here it is immature because the trauma occurred at the age group where the root was still forming. So then we did a CBCT, and in the CBCT, we can again appreciate the extent of the bone loss. The labial cortex was almost gone. So we resorted to non-surgical endodontic treatment in this case because the child was still an adolescent, and there was more hope for regeneration to take place. So when we did, it was around a year, and we could appreciate that simple non-surgical endodontic management could result in a proper approximation of the bone loss which had happened, and the cystic lesion has actually healed. So after 1 year, the clinically asymptomatic, we did a CBCT after 1 year and 4 months. And in the reconstructed image, I would just compare the two time points, and you can see that the bone is gone. So the point is that although the treatment is possible, but not everybody will be seeking the treatment at the best of the places. So it's more important that the people are aware of getting the things right. Another case where we did the reimplantation, and you can see that the time period, which was 2 hours, that's beyond 60 minutes, and we do not expect a good prognosis. On the contrary, it fared very well because we did the reimplantation on 16th of March 2018. We followed the patient after 3 months, then 12 months, splint was removed. And if you compare with the normal tooth, which was not injured, you can see that the root is still forming. I will just ask you to focus on that area, on this portion. The root is forming very well, going fine. And that was the follow-up. After that, she did not turn up, but then after a period of 1.5 to 2 years, we could see that the root has formed completely, as good as the normal tooth. So that's again the importance of doing the things right. So another thought which we did was we had an onus on us that we should ascertain what is the awareness of the treatment plan. And I would request Dr. Kalpana Bansal ma'am to just highlight about a couple of systematic review which we did for that.
Thank you, Dr. Nitesh, for the invite. Since our department is handling traumatic dental injuries very often on the regular basis, still the outcome of the success depends largely upon the extraoral time, the patient compliance, and how the tooth is being handled after it is knocked out of the socket. So we thought, what is the reason, and what can be the where is the information gap? And a series of systematic reviews were conducted last year on school teachers, on dental professionals, non-dental professionals. I'm presenting one of the reviews. And in this, we assessed the global status of knowledge among dental professionals for the prevention and emergency management of TDI, and to provide recommendations for the future research. Systematic review was conducted according to the guidelines of PRISMA, and it was registered in Prospero. All the databases were searched from 15th June to 31st July 2020 using text words and mesh terms. Even the search of Gray literature was performed in Google Scholar and OpenGray. A total of 16 studies were included for the qualitative synthesis, and overall it was found that most of the studies which were included were from Asian countries, from South America, Africa, but there was a paucity of information from North America and European countries. And it was concluded from this systematic review that the knowledge of dental professionals regarding the emergency management of traumatic dental injuries was insufficient or low in majority of the studies, and the knowledge of prevention was not evaluated. There was a paucity of studies from countries of North America, Western Europe, and among dental auxiliaries and dental students. There was a lack of uniformity in the number and types of questions used in the questionnaires in different studies, and majority of the studies also lacked details of validity and reliability of the questionnaire. So this can be one of the reasons that there is a lack of information among the dental professionals also about the emergency management of the avulsed out tooth. Now I will invite Dr. Rahul to carry on with the presentation.
Good afternoon, everyone. Like in the present case, the case was first seen by oral surgeon. They have done their part. They have provided the emergency treatment. They have transferred the tooth to the normal saline, and they have further referred the case to us for further management. But like this is not the case all the time. Not all the time there are dental professionals in the medical emergencies. So many a times the physicians, the pediatrician, the general surgeon are the one which come across this kind of condition. So their knowledge about the traumatic dental injuries and their emergency management have significant impact on the prognosis of such kind of injuries. So considering this, we have conducted a systematic review to evaluate the global status of knowledge about the prevention and emergency management of traumatic dental injuries among non-dental health care personnel. The systematic review was performed according to the standard guidelines of the evidence-based medicine. The PRISMA guidelines were followed for prior protocol preparation, and the protocol was registered at the Prospero. Different databases were searched, and after searching the databases, 2590 articles were obtained, and the additional gray literature was searched via the Google Scholar and OpenGray. And finally, we have shortlisted 54 studies, and out of those 54 studies, only 14 studies could fulfill the desired inclusion criteria. And the meta-analysis was performed in 3 domains, comprised of 6, 7, and 8 studies respectively. This is the table showing the type of study and the different participants involved in the different kind of study. As we can see, in majority of the studies, there were a mixed population. While the two study each, they comprise of pediatrician and nursing officials. Thus, from the finding of the present systematic review, we concluded that the knowledge among the non-dental health personnel regarding the traumatic injuries and their management was sufficiently low, was insufficient, or it was low. There was a paucity of studies from the Australia and certain parts of Europe. There was a heterogeneity among the included study in terms of study design, in terms of population, and in terms of the tool, that is questionnaire, that questionnaire used. So apart from this, there were many studies which are not mentioned about the how they have performed the validity and reliability. Now I would like Dr. Mr. Prakash Mathur sir to give the concluding remarks.
Thank you very much. So what we did is, because we see a lot of trauma and we see the gap, we also keep writing certain articles for our colleagues. So this was one of our articles which was published in Indian Journal of Pediatrics. And after that, we got so many calls from pediatrics colleagues to take a lecture in their conferences like that. So we are trying hard doing that. In fact, one of the very important areas, Dr. Rajiv and Chimbar sir are sitting here, we also see avulsions while giving anesthesia when they are trying to do for very young children. Once I was called in the CTVS department that some child's tooth has come out while doing it, what should we do? I ran there and we could replant and we could tell them how to position it for the time being, and later on that tooth was saved. So these are the things which we want the cooperation from our colleagues everywhere, especially the ones those who are in the emergency duties. But yes, as a doctor in your family around you, people would be contacting you if there's a knocked out tooth. So this little bit knowledge would be definitely helpful. So the take-home messages are: replant the avulsed permanent tooth and stabilize prior to referral if you see any. The golden hour of avulsed permanent tooth have best prognosis if the extraoral dry time is less than 60 minutes. Storage and transport must be done in a physiological media such as bovine milk. And the simple steps to reduce the morbidity and save the patients from adverse consequences is important. One more important thing is, many times, means previous times, 10 years back, people were not much aware. Today, the child is so much aware. They are on social media. They are so much aware about their own appearances. I'm treating children, 2-3-year-old girl, if they are coming, they would wear matching clothes, matching shoes. They would like to have a hairband matching. So that kind of cosmetic and aesthetic sense the children have these days. The boys would like to have macho image, 3-4-year-old. The one which we used to, when we were studying, we were used to be told that the kind of appearance related consciousness comes in the adolescence. But nowadays we see it in 3 and 4 years of children. So for them, losing a tooth would be a big psychological trauma. And a little bit of support from our colleagues everywhere can reduce that psychological trauma. Thank you very much. Any more questions? Ajay sir, would you like to give some remarks?
Basically, this is a slightly a deviation from a CCR, but definitely it is important because these children, if they lose their teeth in the casualty or in the OPD or in the operation theaters, and they are not replanted, this has got a long-term effects on their function, aesthetics, and even a psychological makeup of the child. So this is a slightly deviated from what a regular CCR would be, but kind of a more of an information base. So that because this kind of information, as we have done a lot of meta-analysis and seen that even medical professionals, those who are in the ER may not know as to what is to be done with these teeth, and many of them are actually just thrown away in the yellow bin in the casualty. Yeah. So this is open for discussion. Please, we'd like to answer any question.
What do you do with all teeth in adults? So we replant. In adults also it is replanted. So there is a question on the YouTube. What is the maximum time to replant the tooth? So there is nothing maximum or minimum. We should try to minimize the external time. And if the socket is suitable, it is better to replant and try. Even if the tooth prognosis is poor, at least when the tooth resolves due to foreign body reaction, the bone will get formed, and that site will be ready for the adults, especially for the adults. The site will be ready for future implant and better prognosis for that. But regarding the milk teeth, we would restrict that. We would try to be minimal into that, because sometimes pushing your tooth will actually damage the permanent tooth. So that loss is for the rest of the life. Then we've got more questions. थोड़ा सा font size बड़ा हो सकता है. So we do have national and global policies which stresses upon involvement of medical professionals, but still we could not achieve that level. What can be the reason for this? The reason for this remains the low level of awareness, and everybody has to work hard to achieve. And the next question is, what do you mean by patient compliance? When can he go back to his normal diet after the procedure? Patient compliance is actually the patient reporting back to the reporting back on the scheduled follow-up. So for every patient, the follow-up is little different. So in case of splinting, we call them weekly for the first 4 weeks, and after that every 3 months. If they do not come, then it is non-compliance. The patient can have normal diet normally after 3 days they can go back to their normal diet. No hard diet, but they can go to normal diet.
No active biting.
Not active biting using those teeth, but remaining normal food they can have. Any more questions on the floor?
Being a medical profession, I did not know about this. So thank you very much, sir, for your wonderful presentation. And this kind of a thing, it requires a lot of public awareness. So how can we go about regarding this? Because if you don't get take within an hour or two, that whole thing is...
It takes time to reach to the public, especially in this country. So we created one association by the name of Indian Society for Dental Traumatology. We are trying to do several steps for school teachers awareness, especially where the Sports teachers are there for them. We have got a module to train them how to handle. Then we have for pediatricians, like that we are trying to create little more awareness. But yes, it takes a lot of. Yes, we have dental trauma app. Rather, there are 2-3 apps, and Dr. Nitesh Tiwari is in the process of making one for the school teachers. Sir.
Curious about the milk. Which you have been
Sir, actually, when the accident happens, whatever milk is available, that's fine. At least it will keep the cells viable for some time. If we try to say, okay, you have to get bovine milk only, or you have to get boiled milk or cold milk, then the confusion happens. And actually, the time is very important at that point of time.
Okay,
So
it's just that it is available. So you
yes, yes, yes.
So, I'll just clear that point. Actually, the tooth is the viability of the tooth to take up in the bone will depend on the peduncle ligament survival. And the peduncle ligament survival has to be, when you're giving a solution, it has to be an isotonic solution. Actually. So, the milk is the closest one. The other one would be just putting it in the mouth in the saliva. The other one would be probably the implant, but in that case, we will be introducing some infection. So, these three things could be done. But a normal saline also, if you don't have anything, you just bring it and then we can always transfer it to some kind of different material first of it. Yeah, I think that is the answer, right?
So very rightly said, sir. The thing is that the researches which have been going on in terms of viability, which sir has very rightly mentioned, so they are based on either the solutions which are available in the lab, like we have HBSS, DMEM, or we have the solutions which are readily available when the injury occurs, like milk, ORS, egg white. So there are different studies. China has more of green tea being done. Kerala has got more of coconut water being done. But milk being universal, it's been advocated for.
It's a very basic and challenge.
Yes.
At the spot, patient is with an accident with a broken tooth. Whose saliva we should.
No, child's own saliva, not nobody else. So our colleagues, those who are in Chennai and Kerala, when they do a school teacher training program, they train them that you put the tooth in coconut water and drink. It's available there. In Delhi, we would talk about milk because most of the houses will have milk. So it's little different at every place. In Australia, all the schools, wherever there are child playground is there, they have something called as tooth saver. So there is one balanced salt solution is there, which is there in a bowl, and it is kept in their emergency kit. So if there is a tooth coming out, they will store in that, and then they'll bring the child to hospital. But that is Australia. They can reach in 1 hour or 2 hours maximum to any hospital. Here in India, nobody reaches, and they would say, "Kal subah jayenge."
Or use the medical unit. You can include this.
Yes, this is the next step to train.
We are doing as an ICMR funded project for training of the school teachers. We already have that. So as a second stage of that, that's what sir is implying on that. And as a second stage, we probably might have a better things for that. Yes. If it is what, yes, that's what we advocate, that the patient or the parent should do it himself or herself.
You put it in the mouth and come to the hospital. That is far better. But if there is a lot of blood, it's not visible. If there is a dental trauma, it cannot go. You hurt the child somewhere, then it is not advisable.
So on a lighter note, when I'm taking a BDS final year examination, so my most common question to the candidate is, what happens if you move out and you fall down and your tooth comes out? And invariably, 70 to 80% will reply, I will go to the endodontics department and put it in saline. So the best thing will be to put it inside the oral cavity, because that's what we want. We want to minimize the time period. So that's what the presentation is about.
Thank you.